Dr. Glass, thank you very much for joining us here on Health Connection. Our topic is breast cancer. Technology is the key. And on the subject of technology, advancements in technology have undoubtedly changed outcomes for patients. Let's talk about technology with respect to detecting breast cancer.
Absolutely. So I think one of the biggest changes has obviously been we've moved from film to digital, and that has really added a lot of advantages to the patient in a lot of ways. The first of which is they no longer have to carry their films with them when they go to a different hospital. We now have CDs, which are much easier, and if they stay within our system, then we have everything recorded for years back. So it makes it much easier for us.
Is the quality of the images, or there's more detail shooting digitally?
The quality of the image is very good. The other thing that we have is we can zoom, we can magnify things that we didn't have the ability to do before. So that also really helps us diagnostically.
All right. Well, one approach that's getting a lot of attention in the media that you hear about, talked quite a bit about, is 3D technology, also known as tomosynthesis. What is tomosynthesis? Why is it getting so much attention, and is that attention well deserved?
Sure. So before, what we would do is what we call a 2D mammogram. So there's two views. We can press a female breast craniocaudal, so this direction, or medial lateral, so this direction. And it would really only give us two pictures for each breast. But now what we have is something called tomosynthesis. It's a different type of technique. It essentially creates slices of the breast. I guess the best way to understand it would be it's like a CT scan, but the technology is actually different the way that we acquire it. But what it really allows us to do is to see a 3D image of the breast as opposed to just a picture. So it's much better.
Women's breast tissue can vary greatly, some more dense than others. Those changes in density, why does that make it difficult as a physician for you to see what's going on? And how does 3D technology here at UT Health Northeast help with that?
Sure. So as a mammographer, there's two things that we're looking for to indicate cancer. One of them is calcifications, which are very small pieces of calcium in the breast. The other thing that we're looking for is a mass, like a breast cancer mass, something that would be more invasive. The denser that a woman's breast tissue is, the harder it can be to see. Just like anything else, you get superimposition of tissue and then you can't see a mass. It doesn't stand out as much because the background picture is so dense. And the technology that we have here at UT is that we have the tomosynthesis, and what it does is, instead of being all superimposed on itself, I get individual slices of a woman's breast, and I can work through that dense tissue and really look for what I'm looking for and see much better than I could in the past.
I think you may have just answered this next question, but let's ask it anyway. The difference, just give us a little color on the difference between a 2D image and a 3D image, and why it's important for a patient to have the benefit of the 3D image if it's available.
Sure, and one example would be, so if you take a picture of trees, all you see are the trees, right? I mean, it looks like one superimposed image. But if you're walking through a forest, each individual tree looks different. And that's kind of the difference between a 2D picture of a breast, where all of the tissue is superimposed on itself, where all the trees are superimposed on each other, as opposed to seeing each individual aspect of each tree, each individual portion of the breast.
It's my understanding that there is technology here at UT Health Northeast that's among the first in the United States, the GE tomosynthesis unit. Why is that important, and why is that important to patients?
Sure, so it's really phenomenal technology. The GE company has been very helpful with implementing and helping us get up to date with everything. The reason it's so important for patients is because some places are still not offering tomosynthesis. And so there's something called a callback rate. So women come in for a screening mammogram, they have no history of breast cancer, and they get a mammogram, and they leave. And then I look at it later. If there's nothing wrong, they come back in a year. However, if I see something, then they have to come back. They're called a callback, and they have to get more pictures for me to be able to decide, is this something concerning that I then need to biopsy, or is it something that I'm not concerned about and we can go another year? With tomosynthesis, it actually reduces our callback rate because we don't need as many pictures, because essentially our pictures are so much better the first time. So what it means for patients is they only have to come once, they probably won't have to come back, and they won't have to deal with that anxiety that's created when you get a phone call from your doctor saying, we found something on our mammogram, we need you to come back. So I think it's extremely important for patients.
Well, that makes sense. Let's talk about mammograms. There's a debate, a little bit of tension between the medical community and the government as to when a woman should get a mammogram, how frequent mammograms should be. What do you tell your patients with respect to the timing and the frequency of a mammogram examination?
Sure. So I think the guidelines that you're referring to are the U.S. Preventive Services Task Force guidelines. Those are not supported either by the American Cancer Society or the American College of Radiology. Those recommendations that the U.S. Preventive Task Force says that a woman doesn't need to be screened until she's 50 and that she only needs to get screened every 2 years. We do not recommend that. We recommend what the American College of Radiology and the American Cancer Society says, which is annually every year after 40. And that's really what we recommend. It's been shown to decrease morbidity and mortality, and that's what I tell my patients.
Discuss MRI. We've heard that. MRI technology and its role in helping doctors see through dense breast tissue.
Sure. So MRI is a really phenomenal technology. It's very different from both regular mammography and tomosynthesis. It's something that's to be used really on patients that have a higher risk of breast cancer, but the reason that it's so good is because it tells us something about the actual behavior of the tissue. Whereas the other, with mammography and tomosynthesis, we're taking a picture of the tissue. This is actually telling us about the behavior because we give something called intravenous contrast. It goes in your vein and it talks about the behavior of the tissue, meaning cancer is more active than other tissues in the breast. It's more vascular. So it takes up contrast faster and it washes out faster. So I can actually see a metabolic difference in the cancer tissue versus the regular tissue.
All right. The future technology, what do you see on the horizon?
Yeah, so that's always the question, but there's a lot of changes going on right now. I think one of the big movements in all of cancer imaging is genetics. And you've already seen it in breast cancer imaging today. People, I'm sure you've heard, or family members, it's called BRCA, BRCA positive. It's a gene that makes it much more likely that you're going to have breast cancer. And those are women that we screen earlier. We use more specific tests. We do more testing on. And I think that in the future, it won't just be that one gene that we found. It'll really be a movement toward genetics driving screening almost, because of people with higher risk are going to need to be screened more and differently and more frequently. That's
a good segue into our last question. Woman with a family history of breast cancer, should she ask her primary care physician to schedule an appointment with a specialist?
Absolutely. I think it's something really important to discuss for several reasons. One is that genetic testing is now an option. Also, the guidelines are a little bit different for a woman with a family history of breast cancer. We don't just recommend annually after the age of 40. It's actually 10 years before your youngest relative with cancer. So, for example, if my mother got breast cancer when she was 35, we would actually start some screening at 25 for me. So it's incredibly important to talk about with patients.
Very well. Doctor, very informative, and we thank you.
Thank you.